Sciatica. Sciatica is most commonly caused by an extruded disc compressing a nerve in the lower back. This can lead to radiating pain in one or both legs. The peak age for onset is between 40 and 50 years of age, and a physically active job has less risk than a sedentary occupation. It is common, as 3% of the population experience it every other year. Between each vertebra there is an elastic disc. This consists of an outer compact ring with a softer core. In a herniated disc, the outer ring weakens or ruptures and a bit of the softer inner core squeezes out. Sometimes it compresses a nerve on its way out of the spinal canal, and this will give you pain in the area of the leg where this nerve innervates. It is most common to have a disc herniation in the lower back. These nerves follow the sciatic nerve, so that is why it's called sciatic pain. The pain in the legs can often follow special patterns, where each nerve level has a corresponding area. This is why a doctor can get a first impression of what level you have a disc herniation. First, your doctor will rule out that there are any signs of weakness in your legs, disturbance of bladder, or numbness around the back passage, called red flags. If you have any of these, it could be an indication for an urgent operation. However, the vast majority of patients with sciatic pain don't have any red flags, and is therefore treated conservatively with pain medication to let the extruded disc resolve spontaneously. Even though the pain can be frightening, it is recommended that you try to keep active. Specific training exercises or physiotherapy is not needed. In 85% of patients with sciatica, the pain will go significantly back during the first 3 months. But the course can differ, from gradually decreasing pain to a more varied course. If you still have strong pain after 3 months, it is often indicated to take an MRI to visualize the disc extrusion, and in some cases, you could be a candidate for surgical treatment. However, injections around the nerve are usually offered before suggesting surgery, as they are low risk and often patients can avoid surgery. The most common surgical technique is a microsurgical procedure where the surgeon uses a microscope. Here we see the overlying skin, and a small incision is made before the instruments are put in place to make a working canal. If we make a plane on this level, we can see the disc extrusion compressing the nerve and the working canal. Often the surgeon has to remove a small amount of bone to locate the extrusion before removing it. The nerve root is then decompressed. In some cases, a larger skin opening may be indicated, for instance, if you have been operated in the lower back previously. You will be observed postoperatively for a short while to see that everything is okay, before you get back on your feet gradually to come back to your daily activities. It's important to know that even though surgery may reduce symptoms quicker in the beginning, there is no significant difference by about 6 months after symptom onset. And remember that almost 9 out of 10 will not need surgery, so be patient, listen to a doctor, and keep active.